Okay, welcome to the second conversation in our third COVID-19 conversation series. And I'll talk a little bit about that in a minute. And we've titled this series, Recovery and Regeneration in the Face of Overlapping Crises. And this session is on leading and levers, and it's our second session. So welcome today. And before we get going, I'm going to ask Louis Soren. He is the co-chair of our advisory board. He is a friend to public health, a friend to the National Collaborating Center for Determinants of Health, to just say a few words in opening and set us off in a good way. So Louis, please.
Good morning, Claire, and thank you. And thank you to everyone for being with us and joining us in the circle today. I have the pleasure of co-chairing the NCCDH. I also have a greater pleasure, and that is to serve and to help and to be available to Claire. I recognize her for her skills. We have all been through something that's significant for the past 2 years, and some of us even longer. And for most of us, it's not over. And I asked the Creator to sit with us, to be with us, and to guide us. And the ancestors are with us, and those that we care about are with us. And I asked them to whisper in our ear what we need to hear. I asked our ancestors to guide us and give us a sign that we're on the right path, and that bring us back to the good road if we feel lost, because we've all felt those feelings during these difficult times of the pandemic, and we've all been impacted. So I ask that this circle keep us strong and make us strong today, so that we learn from each other, that we feel gifted in the end by what is shared here, and that we have the courage to speak of those things that we don't have the strength to speak about yet. And if there's something that needs to be let go today in this session that we don't feel we have to carry anymore, that we have the courage to say that and know that it's a safe place, and it's a place that we can receive from each other and give to each other. So thank you, Claire, again. It's an honor for me to serve and to contribute.
Thank you. Thanks, Louis. Thanks for that. That was good words. Thank you. So I'm going to share my screen, and I'm going to open the slides. Just 1 second here. Is that working? Yep. Okay. Good. And I'll just use slides for a few moments here. I'm going to try to see if they work. Okay. So I'm Claire Bedker. Let's see if I can, there we are. I'm Claire Bedker. I'm the Scientific Director at the National Collaborating Center for Determinants of Health. And I've actually been in that role now for 3 years, which is amazing how quickly that time has gone by. And I will host today's conversation. And I just want to start by saying that the National Collaborating Center for Determinants of Health is located in Mi'kmaq. That's the ancestral and unceded territory of the Mi'kmaq. And Mi'kmaq is covered by the treaties of peace and friendship. And just as you were speaking, Louis, I was thinking about those words, peace and friendship, and caring about us and guiding us and finding that good road. So Mi'kmaq is covered by the treaties of peace and friendship. I am joining you from Treaty 1 territory, which is the original land, the ancestral land of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and it's the homeland of the Métis Nation, now commonly known as Winnipeg, Manitoba, just on the heels of a big snowstorm over the weekend, and more snow coming on in late April. So the National Collaborating Center for Determinants of Health is one of 6 national collaborating centers for public health that are located across Canada. And the NCCs, as we call them, are knowledge translation centers, and they were funded and are continue to be funded by the Public Health Agency of Canada with through a grants and contribution agreement to 2028. And we came into being, or were created, the 6 centers right after the SARS pandemic. And each of our centers has a unique focus, and each is hosted by an academic institution or a provincial government. For the National Collaborating Center for Determinants of Health, our focus is on the structural and social determinants of health, with a very particular and sharp focus on health equity and advancing health equity. So I'd like to start by thanking Miriam Richard and Tia Mata for their leadership and their support as members of our team at the National Collaborating Center for Determinants of Health. And we also have several other members of our team online, and they're going to introduce themselves in the chat box. Right now, I know we have Hannah Clausen on and Diana Oiko, and I think Nandini Saxena was planning to attend today. So what I'd like to ask you to do is to use the chat box to introduce yourself, perhaps tell us where you are, what your position is, and you can do a land acknowledgement in that way as well. So why this series? Why are we having a conversation series? And this is number 2 of 5 in this 3rd series of COVID conversations. So in this particular one, the 3rd one, we're exploring listening, leading today, recognizing systems of power, and fostering courage and hope. Our final 3 conversations will be about power, systems of power, rebalancing power perhaps, and about fostering courage and hope, always looking for that equitable or regenerative public health system into and through recovery. What are our hopes? And Louis, you just set us off in such a good way. We hope that through these conversations that we create a space for all of us to come together, to heal, to recover, to regenerate, and to vision something new, something better. But mostly to be together, even though it has to be virtual. And in our pre-session, Louis asked, has anybody met together in person? And you might want to share some of that in the chat box. We have not, as a team, had the opportunity to come together in person. We also want to encourage you and us together to listen deeply and to actively engage with communities, really as a legitimate and important piece of public health action in this phase of recovery. And there's multiple ways for you to participate today. First of all, as I said, introduce yourself and connect with others in the chat box. Please make sure that you share questions or comments or feedback or responses in the chat box as we go along. Tia is going to moderate in there and be in there, perhaps asking you questions and talking with you, sort of kind of like 2 conversations going on at the same time. Please join us in the breakout groups. We'll be together till the top of the hour, so about another 50 minutes, and then we're going to go into small group through Zoom, smaller group discussion. And when we did that in the first one of this particular conversation series, it was really powerful what we heard in those rooms. People really had a very, very strong need to talk to each other, to share experiences, and to think about the way forward. So please consider joining us in those breakout rooms for small group discussion. And our guests today, our panel, will stay with us, and we'll ask them when we come back to plenary after that small group discussion to give some reflections and some thoughts about what they heard in that small group discussion. And then there's also an evaluation survey. And we welcome all of your comments, all of your feedback, and all of your ideas. So please complete that evaluation survey when it comes to you. And email us anything to our email address right there, www.nccdh.ca. We monitor that email and welcome your comments and your participation in our work. Okay. So today, part 2, leading and levers. And some of the topics for conversation today are around core values of leadership. And one of the questions on registration was around how kindness and caring would figure into some of the core values of public health leadership, especially to address and advance equity and equity issues. That importance of deep listening, and compassion in leadership. And we want to talk about levers. What are the supports? What are the mechanisms? What are the things at a personal, organizational, and at a system level that actually support or help us to lever our individual and therefore our collective leadership? And we want to talk about how we together and as individuals drive those equitable actions forward across sectors and across systems. Just foreshadowing and a little bit of a heads up is that we have 3 more in this particular 3rd conversation series. The next one is part 3, and it'll be on Wednesday, May the 11th. So please join us again there. And like I said, please email us and connect with us in any way that you can or want to. Okay, so we have 3 guests with us today, and the way that we have organized our COVID conversations is really try to foster virtually a space in which we can have those kinds of conversations, whether we're using the chat box, we open the mic. I'm going to stop sharing my screen. Or, is that okay if I stop sharing now? Are we back to? Good. So we have only 2 of those 3 guests with us today. So we invited 3 guests, and one of them just this morning, unfortunately, and she's really disappointed, Christina Sims. Sim is not able to be with us. She's from the Yukon, and so we'll try to have her in one of our subsequent series. But we have 2 esteemed guests here with us today. Louis has already spoken a bit, and we have Dr. Lawrence Lowe from Peel Region. And they're going to talk with me and with us about leading and levers in challenging times, but also in times where there is an opportunity for regeneration, for system reset, for renewal. And they'll explore things like collective healing during times of divisiveness, leadership that lifts up our community priorities. I know they've got lots of good stories, and I'm going to ask each one of them to at least tell us one story during this time together. And really to help us think about where are those levers to move public health into a new space, into a new time, or maybe continue that journey forward, where equity is a firm stance, where it's a must do, not a can do or should do or might do, and where all the voices are valued. Okay, so I'm going to start by an introduction, and I want to thank both Louis and Lawrence for taking time out of their very busy schedules to be with us here today. And I was adding up the number of years of experience of the 3 of you. Christina Sim was with you, and I thought to myself, you have together, the 3 of you would have had over 100 years of experience as formal leaders. And we're probably not at 100, but let's say we're at 70 years between you of formal leadership experience. And each of you, Louis and Lawrence, have really led and been called to lead during the past 2 years in very difficult and challenging circumstances. So our questions today, we're going to start pretty generally and ask around, what does recovery or regenerating look like for you? What leadership role have you been able to play? And kind of where you see things going, and maybe just 3 or 4 minutes. We're going to have lots of opportunity to talk back and forth. So Lawrence, I'm going to start with you. And I'm going to just give a brief introduction, and then you can add to that brief introduction and open your comments however you want. So Dr. Lawrence Lowe, thanks for being here with us today, is a physician, and he's currently the medical officer of health at Peel Region in Ontario, very large, diversely populated region within Ontario. And as being a Manitoban, it always is startling to me that there are actually more people in Peel region in Ontario than there is in the whole province of Manitoba. So prior to coming to Peel Public Health, Lawrence worked at all three levels of government. And I think that would be really interesting to hear your perspective, Lawrence, on leadership at all of those three levels of government. He's worked at the local level, he's worked at a provincial level, and he's worked at a federal level, and a provincial level in 2 provinces. He worked at the Public Health Agency of Canada in the Vaccine Safety Division, at Fraser Health Authority in British Columbia as Medical Officer of Health for Burnaby, and the Tri-Cities, and as a Senior Medical Consultant to Ontario's Chief Medical Officer of Health, so at the provincial level in Ontario. So Lawrence, I'm going to ask you to start us off in terms of, what does recovery and regeneration look like to you? What does it mean to you? And where do you see that leadership and those levers for leadership playing into that? So over to you, Lawrence, and then we'll go to you, Louis.
Thank you, Claire, for the introduction and for the opportunity to speak today. It's an honor and privilege to be sharing the podium with Louis, and certainly wish that Christina would have been able to join us as well. But certainly recognize that health comes first, and I think that really is is what I would start with in terms of thinking around recovery, reflection, and regeneration in the post-acute phases of the pandemic. And I really actually want to preface my remarks by stating that, I can see the participant list. I know many of you have also played significant roles throughout this response, throughout addressing the most significant crisis that has faced both public health as well as the healthcare and health systems in Canada that I think we've seen in recent memories, and likely, hopefully, won't see for quite some time yet. But I think when I think about what recovery and regeneration means to me, it really is about some things staying the same and some things changing as it pertains to, as it is relative, I think, to the last 2 years. So I think some of the things that will change is that we do need to really be deliberate and to start slowing down the pace. I think many of our staff, our leaders, certainly in our health unit, but I know in public health organizations, agencies, wherever you might be within the systems that support and that result in decisions being taken. I know that all of us who've been working in this space have been working flat out for the last 2 years. So, one of the things that needs to change is certainly this feeling of constant urgency, this feeling of constant response, this feeling that it's normal to be running at 100 miles a minute. And I liken it to when you get off the highway and you're driving in the city again, it suddenly feels really slow, but that's actually how fast you're meant to be going. And so I think it's really vital to ensure that at least in reflecting and regenerating, we take the time to recalibrate essentially our own expectations of ourselves, our energy, the demands on our time, the balance of our work and life. All those other aspects are going to be critical, because that's how we're going to be able to remain clear-headed and to be able to move forward in some of the decisions that are happening. There are other things that obviously won't change. I think for many of us, this was, for many of us who worked in the public health space, this really was an unprecedented opportunity to engage with our communities in ways that were that were heretofore, mired in competing demands, in different, bureaucratic structures. And I think out of that, we've really had the opportunity to develop, both relationships as well as trust through shared adversity and shared challenges together. Maintaining that is going to be absolutely vital as we move forward, because ultimately, what we do in public health, our policies and our programs do serve the community, and they do need to be able to serve different parts of the community well, and to ensure that everyone is getting their fair share as we think about some of the inequities and disparities that we're confronted by. But because we're going to be changing the pace at which we're doing things, we need to also make sure that we are keeping our partners clear, ensuring that we're being transparent about the challenges that we're facing, about the changes and the transformation within our organizations as we take the lessons learned for the pandemic. And it's not that we don't want to keep moving forward. It's not that we don't want to keep advancing or progressing, but it is about really taking that time to make sure that we are able to continue productively engaging in that relationship going forward. So those are some of the things I use examples in terms of things that will change, just in terms of the expectations and the transparency that we have with our partners in moving from the response and also the pace of our work. But I think there's also things in rest and recovery that will need to stay the same. And I think, moving into recovery, we are still going to have a lot of uncertainty, a lot of this, and frankly, healthy tension between restarting services the way they used to be and applying and reinventing and thinking through before we restart. We have this sort of once in a lifetime opportunity to infuse new concepts, new ideas, to really rethink, the way we did things previously. Was it effective? Was it cost effective? Was it equitable? All of these other considerations can now be applied to some of the programs that we've stopped that maybe we never really had the opportunity to think through and address. So I think there is that, as we move through this tension, there is going to be that push and pull of trying to figure out what we restart sort of status quo and what we basically continue to try to reinvent. And that is going to still require us to remain flexible as the response continuously was changing and evolving. We are now building another airplane as we're flying it in the same way that we did through the pandemic response. In essence, restarting and recreating, public health organizations, the public health sector as a whole. And I think that, I'll close by just saying that requires us to keep 3 cardinal rules in mind that I think were also cardinal rules during the pandemic response. I think the first thing is, at the time where you are going to be making decisions, you may have to make a decision that may yet have to be reversed or changed in the future. As more information arrives, as new information arrives, as the situation or context evolves, you need to be able to be okay with the idea that you may take some decisions in the early phases of recovery and restarted programs that may need to be revisited. I think the second thing is also to really ensure that you are taking the time to take a breath. Right? Sometimes there's a lot of stuff that's happening. It feels like you're just making decisions, or pausing decisions, whatever. Because sometimes it's good to just stop and actually take a look at everything and say, all right, you know what? I'm going to take a deep breath. I'm going to pause, and let's just let the pieces stop so that we can actually, take a moment. So there again, it's that tension between trying to move forward on decisions and taking the decisions that you have, knowing that they may well be reversed. And then when you get to a situation where there's too much going on, to be able to actually take a deep breath and to pause. And I think the last thing is also just to understand, though, that we do need to keep moving in some form or another. And of course, we keep moving with the idea of rest and recovery in mind. We do keep moving with the idea of a new pace in mind. But it is about trying to continue progressing forward and understanding that you're not going to have all the information or all of the decisions taken in other spheres or other systems for you to actually be able to, before you're actually able to act. So being okay with that uncertainty, making those decisions knowing that you may need to change them, and sometimes taking the time to just take a pause and take stock. I think those are things that we've all done through the pandemic, and those will continue to serve us well in the recovery phase as well.
Thanks, Lawrence. And, you remind me, I've had a long career in public health, and I've had many incredible opportunities that I'm incredibly thankful for. But as you were speaking, I was reflecting on some of those leaders that have been really influential for me as I've learned and developed my leadership over time. And whether they walked beside me, whether they were staff that I had the privilege to work with, or whether they were, in a formal structure, hierarchical structure, those that I reported to. But those cardinal rules or those characteristics or attributes of a leader, as you described them there, there was a number of people that came to my mind as you were speaking, you being one of them. So well done. And thank you for the incredible leadership that you provided in Peel Region, but also across the country, and to us here at the NCC. So thank you very much. And I think you live those rules as you work every day. Louis, I'm going to go to you now, and then we'll come back. I see that there's a pretty active conversation going on in that chat box. Thanks, Tia, for leading that, and for folks having the opportunity to speak to each other and to us through that chat box. Louis, I'm going to go to you and ask a really similar question. And you spent the last 2 years in a very different space and position than Lawrence did. But what do you see in terms of, as you look forward, in terms of recovery or regenerating? And where do those leadership opportunities, leading opportunities, but those levers also in your vision, Louis, as you look forward? And Louis, I don't think I introduced you, so I'm going to back up while you're thinking about that, and I'm going to introduce you. You are the co-chair of our advisory board at the National Collaborating Center for Determinants of Health. And I would call you a leader in health equity. I've had many decades of opportunity to work alongside you. Louis is an Indigenous helper. He's a retired professor, and he's a leader and a clinical social worker. Louis has had a long career caring, leading, and contributing to the advancement of community-based mental health programming, suicide prevention, and HIV education, always through a lens of cultural proficiency and sustainable locality development. Louis' areas of interest include dismantling racism, community development, decolonizing methodologies, and cultural proficiency in healthcare. Over to you, Louis.
Thank you. Can you hear me? Okay. Thank you for the invite and the opportunity to join this circle. I'll leave that to the interpreters to interpret. It's Cree for Red Buffalo Man, and I belong to the Wolf Clan. I say that because it situates and grounds me in my purpose. And I'm a firm believer from a young age that vision cannot come unless you have purpose. And so if we're looking at each other and if we're looking within ourselves to figure out what's next and how to help others move in that direction, we have to be clear and we have to do the work, the internal work and the relationship work to know our purpose. And our purpose is what helps us design our vision for what we need to do. And it helps us to stay true. So I have had the pleasure in my career to work with many, many gifted people who have helped me move forward and guide me through difficult times. And one of the things that I value the most about a good leader is that they acknowledge their vulnerabilities, that they are human and that they are willing to live with who they are and help others and ask others to help so that it becomes a collective enterprise and exercise. So as I look at what we've been through, I have had the time and the opportunity or the privilege of reflecting a little bit. And this might sound odd, but I really, from the onset, although it was going to be challenging and we knew it was going to be a difficult time, I also saw it as an opportunity to ground ourselves and situate ourselves. And I was a witness to a lot of people who developed relationships that they had not cultivated in the past, that they had no time to take care of. Relationship with the land, relationship with the place, relationship with locality, relationships with themselves and with family. Because in our rush and in our busyness, we sometimes neglect ourselves in that regard. And so that's the first thing that I would call on us to, as leaders, and as participants and witnesses is to not forget what we've learned through this crisis, because we tend to be in public health and healthcare and institutions and organizations, these systems are coded to be ahistorical. They are designed to be forgetful. And so we tend to replicate, and its power is in replicating itself, not necessarily moving forward. So what we've witnessed should be brought forward. What we've learned and what we've experienced is important in the decision-making process of institutions and systems. So one of the most central features of this crisis is that most of us, or many of us, now understand in a much deeper way what equity is. We understand that it's not 10 miles away, it's next door to us. That equity is with us and it's part of us, and we've all been affected. It used to be an othering process where equity was about other people and it didn't have to touch us, that we were protected or privileged. But now we understand that it is close to home. It is in our home, these inequities. And so we have a role to play, and we can learn from what we've experienced so that we can apply what we've learned and what we've experienced. So it's a different form of knowledge that we've been exposed to, that we've been witness to. It's not a knowledge that had a place when we talked about decision-making, policy setting, but now we know that equity is a viable factor and something that is essential. So I want people to, I'm hoping that we can have the courage in our voice and in our action to make it the centerpiece of our work rather than a value add at the margins. I asked a group of individuals that I was working with recently in the last 6 months, and they had a mandate to talk about and develop solutions and fund proposals that were related to mental health of youth. And I asked the funders what was the status of the equity work in the proposals that were received. How much equity work and how much attention were they paying to equity? And they were honest enough to say that most proposals had not started to work with equity. A lot of reasons were given. We don't know, we don't have the relationships, we're not ready, we're still testing, this is part of our expansion process to go into those settings that are more vulnerable, all that kind of, those are all the reasons given. And I said, why didn't equity be the first place to go? Why not go to those communities and to those groups that would need this work, your work more first, in a sense? And it kind of stopped the conversation because people said, well, we have never had those relationships with those groups and we don't feel safe, or we don't feel ready, or we're just trying to increase our there's a word for it, but they were trying to just kind of expand the program more broadly, and eventually they would get to it. And I found that sad because it means that the last 5 years they didn't really do equity work, and so those needing the work fell more behind. And the place where they could learn the most had been ignored. They went to where it was safe. And I think they went to where their knowledge resonated. They went to the place where they could have more compliance and less conflict. They went to those places that they had existing relationships with. And it reminded me that equity is a relationship foremost, mainly. Equity starts in relationships. And so if you don't cultivate those relationships, then it will be a power relationship. It will be a power-based, control-based, privilege-based, elitist-based. It will be an academic exercise, all these things. And there's nothing, it's not that these things are bad, it's just that these things are limited. And so investing in community for the sake of relationship and becoming not just a partner, but a brother, a family member to the issues that the community is living is very important if you're going to play a role in moving forward. So when I think of what we have to recover from, or what the process of recovery is and regenerating is, I think we're in a place historically in our country where speaking about what is cost effective is not enough. And Lawrence, I want to build on what you're saying, what you said, because it was very, very central and important. Coming out of this pandemic, fiscal restraint will be the first card that's played, whereby they won't want to invest anymore because we've done that. And now we have to recover fiscally from this. And who's going to pay? And there won't be long-term relationships and investments. And that becomes paradoxical for those marginalized communities who for the last 2 years have not seen any controls on what needed to be spent and invested. And all of a sudden there was money available for the issues or to address issues in our country, in our communities. And yet they felt that they've been marginalized in the past. There was always a restraining kind of order on that stuff. So cost effectiveness is not enough in our analysis. We have to do care effectiveness, and that's where equity comes in. So moving from cost effective approaches to care effective approaches, which build in equity as an investment, not a liability and not a surcharge, and not a appeasement process for marginalized communities. This acknowledges, to look at what's care effective, acknowledges that those communities that have been most impacted have also the most to contribute to the change and to the sustaining of what needs to occur. So those are some some thoughts. I think there are things that we need. Marginalized communities have always been mindful and conscious of what they could lose. So hanging on to what is important is central to moving forward. It's not just about innovation and changing. It's about valuing certain things that we might not have invested or recognized as valued in the past. If you think of our seniors, if you think of our communities, if you think of the relationships that are necessary, and that this was a great equalizer, this crisis, in the sense of we've recognized how vulnerable we are as individuals, institutions, communities, and that none of what we want as a vision and as a purpose, as a dream or as a strategy can happen without the relationships that we have discovered or that have been there for us, even at the individual level. The circle of change that we've established with those who have a like-minded purpose, those who have weathered with us some leadership challenges, and who have supported us in those dark times and moments where we wanted to give up as leaders. So, and who have offered their hands to help lift in times when we weren't sure that anyone would step up to do the work because it was risky and it was personal. So, and we've all had some losses. So it's, Lawrence, you talked a little bit about constant urgency and response. And that is, there is a constant urgency that has always been there. Now it's just visible. But the caring response is what will mediate the impacts of urgency. in the sense of taking care of things. So I'll stop here because we have more questions where we can kind of deepen the discussion.
Yeah, thank you. Thank you so much, Louis. And again, some incredible nuggets that came out of what you were saying. And it was really heartening to watch Lawrence actually nodding along with you as he heard some of your words there. There was a question that was submitted on registration that I think I'll kind of combine two because they kind of go both directions. There was a question that said, could you give an example, or do we have examples of someone who has successfully been able to champion a leader from within a community who's experiencing inequities? So those with lived and living experience, that sort of notion of walking alongside or leading from the side. But they also asked, another person asked, how do you lead or influence up? So to an ADM, to a deputy minister, to an executive director. And I did my dissertation, I did my PhD in the space of public health leadership to advance health equity. And I came to understand that the type of leadership or the leadership that's needed, or how I would define leadership, it's about influence and it's about persuasion. So that notion of leading beside, but also leading up we work for the most part in community health and in public health in very formal hierarchical kinds of organizations. So being able to champion or join arms with the community and assist them or open space for them to lead, but then also about leading up. So Lawrence, I'm going to start with you, and then Louis, come back to you in terms of a story or an example or what you've learned in this crisis, and as we move forward around that. Lawrence, over to you.
Thanks, Claire, and those are both excellent questions. And if anything, I think one of the reasons why I was nodding with Louis' remarks for many different reasons, but I think one of the key reasons was I think you really hit the nail on the head at the end, Louis, in the sense that when you talk about leadership and when you talk about recovery and reflection, it's important to talk about as well the perspective that you're taking. So I think my remarks were very predicated on sort of the organizational perspective. Internally, I think that may be reflective of the fact that I spent the morning in a big organizational meeting that was really talking about the future forward for the organization. But I think Louis, you hit the nail on the head with the idea that the urgency has always been there. Equity and disparities have always been, a public health imperative. And addressing those has been a public health imperative for some time. And as I'm always fond of saying, it took a pandemic of a novel infectious disease to remind us that we're all ultimately connected. Like that's the idea behind a community, right? The idea that now it's not just about, dollars and cents around health and social spending and how that can how we're all connected in that way through different services being provided elsewhere, as most people are wont to sort of think about in abstract terms. But now it's like, this is a disease that by virtue of these inequities and these disparities is now going to impact you potentially either directly if you are sick and then potentially severely ill or pass away from it, or in terms of some of the measures that then are required to ensure that everyone stays safe and to ensure that we're actually able to contain and address that, at least in the initial phases before we had treatments and before we had vaccines that could be deployed. So we know that as a community, it's about the relationships, it's about the connections, it's about all of us actually trying to work together to better not just our individual, but our collective health and well-being. And I think that's the fundamental principle around public health. And so I think having that perspective and understanding, when you're talking about rest and recovery, are you talking about the community? Are you talking about the organization? Are you talking about it? Which perspective are you taking? Because I think while it is important, and the advice I've given is largely for organizational leaders and staff, you know, we do need to remember that the fire is still burning on so many other issues in our community. I mean, for example, in Peel, we are now starting again our work to really try to address drug toxicity and its impacts in our community, which was already a fire burning beforehand. We know that mental health and wellness was another burning platform in our community, and these are not going away. These are actually still here, and to a large degree, by virtue of the pandemic having you know, come through, are now, you know, even more exacerbated than they were prior to the human health emergency. So I think that segues nicely into the story that I'm going to share, which is you know, many people don't know this, but my first day on the job as Peel's medical officer of health in an active capacity was actually March 14th, 2020. And so if you all remember exactly what was happening at that time, I think the WHO had just called a pandemic on the 11th. The NBA had just canceled the rest of their season, and we had just been told that March break was going to be extended for 3 weeks, and then of course magically the kids would be back at school. That was exactly 3 days before the first state of emergency was declared in the province of Ontario, in which on my recommendations the day before, I had actually recommended that restaurants move to takeout and delivery in Peel region, together with many other colleague medical officers of health across the province. So it has been interesting, but I will say that the one thing I saw, so throughout the first wave, I think what we've seen throughout this whole pandemic is that open was vulnerable, right? So places that remained open remained vulnerable to exposures, infections, and then the severity cascade that would then invariably follow, you know, if in the absence of treatment or vaccination. So we saw the first wave through, you know, long-term care facilities and, you know, the other really essential businesses that remained open, and then as the essential business list got broadened, especially for a region such as ours here in Peel, we started to see the spread through workplaces, essential workplaces that remained open. And then once you open up the social events, that's when you started to see spread in social events. And I think to a large degree, just even seeing that provided empirical evidence that the closures and curtailments did work to reduce spread and to save lives, contrary to what some of the critics would, because ultimately when things weren't happening, when people weren't meeting, we weren't seeing infections and we weren't seeing those subsequent, you know, admissions, intensive care, and then also tragically those that succumb to the disease in our community. But what was interesting is in the first wave in Peel was pretty much like all the other waves seen throughout the Western world, where, you know, a very vulnerable population in long-term care bore the brunt of the initial infections in our community, and certainly you know, it was that was at the time where we knew very little about this disease, trying to work very closely with that sector to address the needs of that group. But what was interesting was where Peel's story diverged from the rest of the province of Ontario was in the second wave, beyond you know, the long-term care wave. So in the second wave, Peel had the highest rates of transmission and the highest rates of severity of COVID-19 in the entire province. And that really came down to, and thankfully came down to an understanding from our part of our community's makeup. You know, we have a very large goods distribution sector that grew up around Pearson Airport. We had a very large warehouse and manufacturing sector that also grew up around Pearson Airport. And we were essentially the hub for distribution, you know, not just within Ontario, but to a large degree across Canada. Many goods would come in from the United States through the soft border closure that we had. Many of those transport drivers, transport employees would end up getting sick with COVID, especially those who spent considerable time across the border, and then they would seed the disease in our community. That was essentially the pattern we were seeing in the second wave, which was very different from other parts of the country that didn't have a similar makeup in terms of economic and population composition. But remember, I'm you know, in my first year as a medical officer of health at the region of Peel, and I'm still trying to figure out what's what. And I still remember one of the things that I've tried to do as a leader, and some of you may know this, is that when I see someone who's critical of, you know, Peel Public Health or public health or whatever the case is, I like to reach out to them. I like to just say, hey, listen, I see that you've said something in the media that, you know, that you're a little, you know, concerned about X, Y, and Z. And, you know, if you approach, I think, with a certain humility and just say, I'm interested in hearing more from you. most reasonable people will actually respond very well to such entreaties. And that was actually what changed things around for us in the second wave in Peel. I saw some South Asian community advocates commenting on, that they hadn't heard from the health department. I saw some advocates from certain faith communities saying that they hadn't heard from us, the Black African Caribbean community. And I reached out to all of them. And together with my team, we really started reaching out and just say, okay, look, where are we missing this? What part of the picture are we missing? How are we missing all these other pieces? Because again, like many other public health agencies in the first wave, we were overwhelmed with long-term care and overwhelmed with just trying to understand this disease. And I honestly, in my first few months of being a medical officer of health, was just overwhelmed in general. But when we finally got to the second wave and I started to see people say, well, why hasn't public health talked to us? Why aren't they working with us on this? Why aren't they working on that? It became my modus operandi to basically just say, look, I'm going to reach out to the person and, I'm going to give them the time and I'm going to listen and I'm going to basically figure out how me and my team can actually do this. And we actually created a whole team that was focused on community engagement within our emergency response, just on the fly. Together with the regional structure, which had a community response table at the very beginning, which we then basically started sending regular representatives and updates to. And I think the big lesson that I would have learned out of this is that if I as a brand new medical officer of health, if I had to go back and tell myself what to do at the beginning of March, I would have brought the community in way sooner. I would have reached out to these groups sooner. But again, in reflecting and trying not to be too hard on myself, I was also overwhelmed with trying to figure out this new disease and trying to figure out a new organization that was in the midst of a significant emergency response. So I like to think that I can't fault myself too hard for what actually transpired. But I think I can, as I always tell my children, the real mistake is not learning from your mistake. And I think in the future, I think the sooner you bring a community into something, the sooner you really, get a broader understanding of your community. And frankly, that takes time. And that was not a luxury we had during the emergency response. The sooner you see results, because out of that came the high priority community strategy that we were able to, and this goes back to what you're saying, Claire, around your second question, in terms of managing up. We worked with those community advocates to say, here's the stories behind the data. Here's what we're seeing in Peel. Here's what we actually need, we need to reduce barriers to testing. We need isolation centers because people are living in congregate housing. We need to revisit the essential business list. We need paid sick days. We need all these things that, when we are actually able to join together with the other same voices in the communities that are calling for what is right, that is driven by the data and sharing their stories and the color that actually adds to it. I think that actually, both when you're actually putting that out there in public, but also, respectfully engaging with, provincial counterparts, with the heads of other agencies, working together as a partnership. It is that broader idea that we are ultimately all connected, both as a community, but ultimately as a system that creates the policies and programs that actually support or don't support people. So I think that was the lesson that I learned. Bring the community in sooner, because once you do, you actually get a far better understanding and you can do some pretty amazing things together.
Thanks, Lawrence, and thanks for the story. There's always so much in a story. One of the questions that came on registration was, what are the best resources for applying a strength-based approach? And I think you just answered that beautifully. And sometimes that strength-based approach actually comes from that lever or opportunity that was presented to you in terms of a complaint or in the form of a complaint or a concern or a criticism, right? And to step into that versus, shying away from that. Beautiful, beautiful example of health equity leadership in action. And my own experience within multiple organizations is if you've got some data and a good couple of on-the-ground stories, you can influence up. You can really influence up if you've got that evidence, some data, and a very powerful story that has a solution embedded in it. So really, really important example. Louis, there was a question in the chat that actually reacted, and I'm going to focus it to you, where the person said that they like that concept of care effective, okay, versus cost effective. So do I. That's a really interesting soundbite to take away. And they wondered, this is to that leading up, How do we balance this notion of care effective against, it's in a versus sort of way, the proponents of cost effective? So how do we get communities, agencies, governments, leaders, other more senior leaders to change its views on that notion of cost effectiveness versus care effectiveness? So you put that soundbite into our audience and they're interested in how would that look? How would you do that? Or how have you seen that done? Or how have you done it?
Well, before I entertain that, I want to thank you, Lawrence, for what you've shared. I think I'm always impressed and humbled by leaders. And it's not that there's one type, that there's a circle of leadership and we all bring something to it. And I'm thankful for what you bring to this experience and this analysis, Lawrence. When we look at the comparing what's cost effective versus care effective, and we want to do that as leaders, or those individuals, we call ourselves leaders, but maybe we've been tasked to lead and we don't feel like a leader. But the fact is, the reality is, and this goes back many, many years for me, is that we are asked to do certain roles at different points in our journey. And it may be because of the letters behind our name. It may be because the color of our skin. It may be because the eloquence of our voice. It may be because of the knocks we've taken in the past and that people respect that. There's a lot of reasons why we are in a place that we are. I think when we talk about care effectiveness, we have to cultivate the sense of purpose in our leadership. And and that is a long-term journey that we have to start early. And that is a blessing and a gift that comes from the voices of our community, because sense of purpose comes, if you're going to be a leader with a sense of purpose, it'll come through the relationships that you've cultivated that help you with your compass, that will guide you, value compass. And it's also with the relations that are going to be there when decision making has to occur, and because it requires courage. Purpose requires courage. Vision isn't enough. You need purpose. And so how do you cultivate that? And I remember, as an example, a story where at the young age, I was early 20s, and I made the mistake at a conference on mental health, a national conference, because there was a suicide epidemic in Indigenous communities. Remember Davis Inlet, those situations all across Canada, lots of 7 times higher than the national average for Indigenous children, Indigenous youth, Indigenous peoples, even Indigenous seniors. I made the mistake of saying, if we're going to succeed in curbing that pandemic of suicide, we're going to have to work with our community and co-create solutions. And that one statement resulted in me being asked to go and help design the initiative called Brighter Futures in Ottawa. And so I went there as an Indigenous person. Do you think I was ready? I didn't think I was ready. It helped me take that step when there was a circle of elders that sat me down with those I cared about, and also invited someone from the department that I was going to go into, the Department of Health, the Ministry of Health in Ottawa. And one elder said to the director, she said to the director, "We're giving you Louis. He matters to us and we care about him, but we don't want him to get hurt. So take care of him and protect him." It was what I needed to hear in order to assume responsibilities, to do the work. They were astute because they knew it wasn't going to be easy and it could really hurt me, working in a very large system in Jeanne Mance in Ottawa, working with bureaucracies, working with power and stuff. It's not that I was vulnerable or weak. It's not that I was inefficient or unqualified. It's just that I needed those relationships and that understanding that this work would not hurt me. And if you think of each other and ourselves here around this table and the leadership work that we've had to do, it's not easy. People wonder, why are we doing this work? And it sure helps when we know that there are structures, individuals, systems, organizations that protect us. Not that we have power, but that we are protected. And so we can do the work humbly, that we can do the work with others and expose our humanity and vulnerabilities in the process. And when I hear Lawrence talk about benefiting from the relationships that came through community and how early, if you do it early, how it can feed you and how it can sustain you, because it doesn't make it easier, it just makes it healthier. And if you can have that protection, you can communicate the purpose better, right? It's not a it's not a top down anymore, it's a circle. And so working with our community is important. And I invite everyone to reflect in the last 2 years if there's been opportunities for you to better understand and cultivate and regenerate and feed that sense of purpose. Not in a polarized way, whereby we are right and you are wrong. We understand, but you don't. Not in that way at all. Because that's the other teaching that COVID has exposed to us, is that I don't know if we really deeply appreciated how deep the difference was in our communities. The crisis brings out that the gap. And it was powerful to me when the opinions and the perspectives were so polarized. And what do we do about that? And that's not going away. That fire was lit before and now has been fed by the pandemic. And so what do we do? And one of the things Claire and I and others have talked about it a little bit in the past, about how in our society, but also on a more local level, in our traditional circles, we always have contraries. We have people who are so different that it makes our head spin sometimes. We just don't understand what purpose they have, but to create chaos. That's what we think. We think that they're so different that they shouldn't belong. Like, why don't we just shun these people? Why don't we just kind of move them aside because they're getting in our way? They make things so complicated, and we say they're toxic. But if we learn from the pandemic, we realize that these are essential individuals within our system, within our communities, within our circles, and they have a place. That we have to develop the skill sets to move beyond difference and perspectives that are contrary to us. And these are the people in our traditional circles, in our ceremonies. When we laugh or when we cry because it hurts, they laugh. When we want to sing with the drum, they create a bit of chaos in the lodge. When we go right, they go left around the circle. When we're trying to be sacred or trying to be almost monk-like in the sense of really sacred, they joke at us, they kind of throw water at us, they stop us from moving forward, they steal our shoes, all these kind of things. They're not children, they're not less than, they just play a role to remind us about how do we look beyond those things and appreciate. And it's a tough thing to do as a leader, to just align ourselves with those we like, that share our vision. But making space in public health for those other perspectives is the only way to cultivate new relationships. And evidence means nothing if there's a relationship that shows, that lives that evidence. And beneath the evidence, there's purpose and there's a message about caring and respect and the teaching. So how do we moving forward, prepare ourselves? Because Lawrence, you touched on it, we cannot have individual well-being and health and individual level public health without having collective health. So the collective is what creates the individual health. And so how do we cultivate collective processes in our systems so that we are working with our relationships, working with others who belong in that circle, and give it time, because the less time you give to someone who's contrary, the louder the voice will be, the more dramatic the response will be. And then it just keeps polarizing. So how do we neutralize that energy and mediate? And that's the skill of a leader in a sort, to create purpose and space for that individual to feel that they're contributing. So those are some of the thoughts around that. There's a lot to talk about in the sense of what leadership looks like from moving forward at this point.
Yeah, thanks, Louis. Those are some just really, really profound thoughts. We're going to move into our small groups. But for those of you who might need to leave, I just want to remind you about session number 3, 4, and 5, and invite you back to conversation about power, about courage, about hope as we move forward. So Tia, I'm going to ask you to divide us into small groups. We'll maybe stay there for about 10, 11 minutes, and then we'll come back to the larger group and get some final words from Lawrence and Louis as they join at least 2 groups, and we'll end at the bottom of the hour. Okay, so the magic of Zoom will take us into small groups, just for few moments of conversation.
And I agree with you, Marianne and Sarah, that evidence is a paradoxical construct, in that evidence is a reduction of data to things that are provable and observable, but they're actually not, it's rarely truthful because it's always culturally bound. It's always fixed in time, and it's always going to be revisited at a later point and contradicted anyway. And so it's situated in time and space and voice, both structurally and relationship ways. And when it comes to evidence, we have to acknowledge that there are multiple truths, that it's not one prevailing truth. And so when we use evidence, I treat evidence as a seed of light. So think about that, whereby you're trying to use a piece of information or something you've learned to plant it as a seed of light so that others will see something and pay attention to something. And so it's not about being right, the expert. It's not about proving a methodology. It's not about any of that. It's about what do you want to plant that cannot be unplanted later. It'll grow, the light will grow around this. And it's not that I always choose the slow boat to anything. And there is urgency, but the more seeds you plant, the faster people will see. There are points of light, and so that you can't dispute. And those are not always quantifiable. It's in the relationships that those seeds create around that. Because I may not fit well on the bell curve with what I say, but I don't want to be marginalized either as a contributor as far as my voice, or reduced. So anyway, so
thanks, Louis. Yeah, thanks, Louis. And I think we've come back into the larger room and joined you in some pretty profound remarks there around evidence and planting seeds. So we're going to ask each of you, Lawrence and Louis, to just give us some final words, maybe just two minutes, just kind of your final words. But from that small group conversation that you had. But I'd really like to thank everybody for in the small group that I was in, your willingness to share, to listen to each other, to connect, and I think to find our purpose. I had dream with each other, but I think actually, Louis, in the last comments you said in the larger group, is really to find our purpose, and that vision's not enough. So I'm wondering if everybody who's left with us here this afternoon, it's about 35 of you right now, could put into that chat box, maybe just picking up on your metaphor, Louis, one of those seeds or those words or thoughts that you're leaving us today with. So just encourage you to visit our website, to see our resources. There's lots and lots of incredible stories there. Our new Equity in Action is there. We've got a new glossary of terms that are essential to health equity. And to just remind you to complete your evaluation. When it comes, we are just really interested in hearing from you, but also to engaging with you. So please do that. So I'm going to go to Lawrence first. Lawrence, you were in the group with me, and then to Louis. But meanwhile, please put in the chat box here some of those top of mind thoughts or words that are coming to you right now, and then we'll wrap up. Lawrence?
Yeah, so I think it was a great conversation that we had in the breakout room, and I think the one thing I took out of that was really going back to your point, Louis, around the polarization that we now are confronting, and so I think there is this. There is a divisiveness, I think, in society and in our sort of dialogue and rhetorical engagement that's actually going to continue to be a barrier and I think frustrate a lot of efforts around equity and disparities. And I think I also made the point related to that exists both within the professions of those that are working in the public health and healthcare space. I think you just need to scroll through Twitter to see just the extent to which it's impacted our professional relationships. But then also trying to heal within the public health and healthcare and broader disciplinary fields with the same sort of polarization that's happening out there. And so I think I'll leave you all with just the thought and recognition that I hope this session is not a session in isolation. I think it is a part of a broader and a larger conversation. I will admit that when I came back to the larger room, I accidentally turned on the interpretation. I really want to say thanks to Constantin for interpreting. But I think one of the things we'll need to think, because I was able to practice my French a bit, but I think the bigger thing I would just say is, this is the start of a conversation. And the other thing that I would highlight is, let's think about not just, the other things, the continuing dialogue that we'll need to bring to resolve the polarization, to identify the disparities, to figure out a way forward. But let's also think about the voices we're not hearing from, right? So, I think thankfully, Claire, you were moderating today, but I have no desire in general to be part of a panel. And so I'm very sorry that Christina wasn't able to join us, but I think that was a voice that was missing today. Certainly other languages, people with other backgrounds, other pieces, they all need to be part of this dialogue and discussion as well. And so I think as we continue this conversation forward together, let's try to figure out how we address the divisiveness and polarization to better attack and address the disparities. But let's also figure out whose voices we're not hearing from in the recovery and the reflection piece as well. I think that's really important to highlight.
That's excellent, Lawrence. Who are we not hearing from? And how do we go about engaging with them and lifting that voice? And there's many mechanisms and many levers available to us to do that. Not always easy to do though, just recognizing that. Louis, we've got 4 minutes. I'm going to ask you for final words, and then I'm also going to ask you, Louis, to send us away in a good way, in your way. And I would agree with that elder who said you are a gift. So take us home, Louis. Thank you.
Thanks, Claire, and thanks, Lawrence, and to the others who've shared and contributed with us. I agree with you, Lawrence. I mean, what the biggest learning for us through the pandemic is to be witness and to make visible the work that's still there and was always there. And how do we move beyond the issues that come down the pipe, down the river, down into the rapids where we live? How do we move beyond the issues to look at the root factors? And we look at polarization as the difference as a barrier to moving forward. It's actually a root issue. It's deeper. It's more complex, and we have to learn the skills as leaders, but also to learn the habits that are necessary in order to dissolve the tension and friction that comes from that, and not to act like it's not there, because that's part of othering. And we've done that in the past on all kinds of issues, and we'll do it again. So how do we move beyond that? And one of the only ways that we have as leaders and as organizations and as professionals is to be generous and to be patient and to be humble. And those are powerful teachings. It's a powerful style. And rather than feeling wounded, because we all have been wounded by this, we all have been hurt in some level. So how do we find the energy, the courage to be generous, humble, and to be kind when we are looking for something, or healing ourselves? And that's a challenge. That's a true leader in a way. And so how do we do that work? Because the first natural instinct is to protect ourselves, to separate ourselves from all that hurt. But we're not doing ourselves a favor as we face the issues that are, we're going to be remorseful, and we're not ever going to feel complete. The hurt becomes toxic. So how do we work as organizations beyond what we witnessed in order to create new conditions to attend to what's ahead for us, and whatever the issue is? And so what are the new relationships? And be prepared. It's been the most challenging in my career to give myself 100% to certain relationships, and it still doesn't work out. It still hurts at the end. And you've got to have the courage to keep going, rather than should I just give up on this one, or develop polarized impressions about the enemy or the other perspective. So we've got to find room at the table, and there are things we can do to create space so that others are heard, the most vulnerable voices, which sometimes are the most angry voices, and they need to be heard. So how do we create those opportunities? So thank you again.
Thanks. Yeah, thanks. We're right on the moment there, Louis, and at the bottom of the hour, it's 12:30 here. So thank you, Louis. Thank you, Lawrence. Thank you, everybody, and we'll see you next time. Bye.
Take care,
Bye,
everyone.
everybody. Yeah, take
Take care.
care. Yeah, look
Thank you,
after each
everybody.
other and yourselves. Bye now.